আমি ডক্টর অভিক ঘোষ, অ্যাসোসিয়েশন অফ হেলথ সার্ভিস ডক্টরস ওয়েস্ট বেঙ্গল শাখার পক্ষ থেকে আপনাদের সকলকে স্বাগত জানাই। আপনারা সকলেই জানেন যে বর্তমানে আমরা একটি ভয়ঙ্কর অতিমারির সম্মুখীন হয়েছি, যার নাম দেওয়া হয়েছে কোভিড-19, এবং লাখ লাখ মানুষ এখনো পর্যন্ত এই কোভিড-19 আক্রান্ত হয়ে মারা গেছেন এবং এখনো বহু মানুষের মৃত্যু ঘটে চলেছে। তার মধ্যে যেমন সাধারণ মানুষ আছেন, বহু স্বাস্থ্যকর্মীও আছেন। এখনো পর্যন্ত আমরা সেরকম কোনো এফেক্টিভ ভ্যাকসিন বা কোনো মেডিসিন নিয়ে আসতে পারিনি, এবং এই পরিবর্তিত পরিস্থিতিতে AHSD ওয়েস্ট বেঙ্গল শাখার পক্ষ থেকে আমরা একটি ওয়েবিনার বা লাইভ প্রোগ্রামের আয়োজন করেছি। এটি 6 দিন ধরে অরুণ সিং, ওনাকে নিয়ে নতুন করে বলার কিছু নেই, ওনাকে আপনারা সবাই চেনেন। উনি বর্তমানে এইমস যোধপুর নিওনেটোলজি ডিপার্টমেন্টের বিভাগীয় প্রধান এবং RBSK এবং NHM এর টেকনিক্যাল অ্যাডভাইসার। তো আমি প্রফেসর সিংকে ধন্যবাদ জানাই আমাদের এই আয়োজনে অংশগ্রহণ করার জন্য এবং আমাদের আবেদনে সাড়া দেওয়ার জন্য। আমি আর খুব বেশি ইন্ট্রোডাকশনের মধ্যে যেতে চাইছি না। আমি প্রফেসর সিংকে অনুরোধ করব ওনার প্রেজেন্টেশন বা বক্তব্য রাখার জন্য।
নমস্কার। অ্যাসোসিয়েশন অফ হেলথ সার্ভিসেস ডক্টরস AHSD কে ধন্যবাদ যে তারা কোভিড নিয়ে অ্যাক্টিভ হয়ে আছেন এবং সবসময় ইনফরমেশনটা শেয়ার করার চেষ্টা করছেন। এর আগের প্রোগ্রামেও এক সেকেন্ড জাস্ট স্ক্রিনটা শেয়ার করছি। So thank you very much for this invitation. The last time when I spoke, I'll repeat some of the things because it is almost a month now. A lot of patients have recovered. Some who were unlucky couldn't recover. But I think that I have been trying to follow meticulously whomsoever I have come in contact. So there are certain things which will be repetition of my last talk and certain things which will add new. So first of all, just a repetition, but is very, very important that we all know that COVID virus is not something new, but of late in 2002, it started affecting not only the upper respiratory, but the lower respiratory tract infection, and it was being called SARS-CoV-1. After a gap of almost 18 years, 17 years to be precise, in 2019, again, people had a similar picture, and this was now labeled as SARS-CoV-2. So this SARS-CoV-2, like SARS-CoV-1, has a lot of things which are very similar. Number one is the ACE2 receptor through which it enters the cell. Once it enters the cell, it requires help of the cell itself for entry, because the spike protein cannot enter till it is sharpened by the TMPRSS2 gene, which is a part of the protease of the cell inside. Now, this helps the SARS-CoV-2 to enter. This is very interesting. Why does the TMPRSS2 gene help the COVID virus with the spike protein to enter? We really do not know, because all cells would like to protect itself. But one thing is very clear, that SARS-CoV-2, once it enters the cell, it doesn't want you to die. It doesn't want to damage your body. What does it want? Since virus is something between living and non-living, it has to enter a cell to become living, and it will use the cell mechanism, the cell structures for its replication to increase its population. That is the basic nature or the basic requirement of SARS-CoV-2. For it to become living, it has to enter a cell, and it will enter the human cell through ACE2. And once it enters the cell, it wants to utilize the cell mechanisms for its replication. And once it replicates, it comes out, and then it will enter a new cell. So this is how the basic mechanism goes. A word that TMPRSS2, last time also I had said that this is a transmembrane protease serine 2. Not to make it very difficult, a very simple thing, that a cell wall has a cell membrane, and across this membrane, that is why it is known as transmembrane, there is a protein which is supposed to clean the area around it. It is a proteolytic enzyme, serine based, and that is why it is known as transmembrane protease serine 2. This is presented much more in male humans than as compared to females, and it is anchored to the plasma membrane. Now, why this is necessary? Because when the virus wants to enter through the spike protein, it has to enter through a particular door, and that door is known as the ACE2. Now, it doesn't allow it to enter, so the TMPRSS2, it cleaves it, it cuts the spike and makes it in such a way that it can enter. I had also said that patients with prostatic carcinoma have very high level of transmembrane protease serine 2. That means that if I am suffering from prostatic cancer and I have COVID, then this TMPRSS2, because of its more representation, will actually make me more vulnerable for the COVID to enter. So it actually facilitates the human coronavirus to enter the cell. And as I told you, that a lot of people thought that in 2019 we got to understand a new disease known as SARS-CoV-2. So all of us should remember that as early as late 2002, almost all the clinical symptoms are absolutely similar to what has happened in 2019. People in China during the winter months of 2002, they got infected, their lungs became opaque, children didn't have an infection, adults had this population, adult population suffered more. And here also the SARS-CoV-1 had an ACE2 receptor, which came from the bat. So it jumped from the bat to the human beings. Bats were not dying, but human beings started dying. And there also the TMPRSS2 was there. What was the learning was that 26 countries were affected, including India. This time, 213 plus countries have been affected. That time, there were 774 deaths. This time, the number goes as 762,000 deaths. And this has increased. But what is very interesting is that I keep on quoting that this paper of 2005 published in Current Molecular Medicine, it tells that if and when SARS, so this is a 10 pages, last time I also had shared this, but again I am repeating, this is a 10-page article published as early as in 2005, that's almost 15 years back. And the last 5 lines are very, very important. If and when SARS will re-emerge is unpredictable. But if the virus lies low for a couple of seasons, it may lull us into a false sense of security. Over time, funding for research will dry up, industry will lose interest, And we should not forget, we should keep in mind that SARS-CoV and SARS-CoV like virus are still around in their natural animal hosts and are handled in research labs. So he predicted that all this research which we are doing, even the vaccine had started in 2005. They will all get stopped because the commerce, the industry, it will think that their vaccines will not be sold, so they will withdraw this. But we should not forget that the reservoir is the bat is there. So again, there will be a SARS. When it will reemerge, we do not know, but there's a very high chance of reemerging. This was written by Stadler K. and Rupoli. He's still alive. I wrote him a letter and he replied to me that he's not interested because he felt very dejected when people didn't help him with any kinds of funds, etc., when he knew that this is something which can come again. And if I have to compare these two between the 2002 and 2019, where so many people died, one, that it was mostly air spread. So aeroplanes spread it more. Number two, if you compare the features, both had flu-like symptoms, including high fever, malaise, cough. Both had infiltrates on chest X-ray, and overall mortality was about 10%, but that was the first time. And the results of this disease seemed to be milder in the pediatric age group. What was very interesting that all the therapies which we talk of, antiviral, steroid, plasma therapy, pulse steroid, everything had been tried. And there were answers. All we had to do is to go and back and. So the famous quoting, when one's neighbor house is on fire, you too are in danger. And I had said that there was so much of learning that if there's a pre-existing illness like diabetes and heart disease, then the chances of landing up that patient in intensive care unit, this was as early as 2002, this has been shown. This had also been shown that aerosol producing procedures such as ET intubation, bronchoscopy, it helps, it increases the infectivity rate. Hospital staff should wear masks. All this during infection, all this was well documented, including the therapy. Now, what is it that new we are adding? Now, you see, all these years as a medical student and later on, we always thought, what is the etiology? So the etiology of tuberculosis is Mycobacterium tuberculosis bacilli. The etiology of SARS-CoV-1, the etiology of COVID pneumonia in 2002 was SARS-CoV-1, and in COVID-19 pneumonia was SARS-CoV-2. Is it the virus which causes all the damage? If it is so, why some people survive? Some people have mild symptoms, they become well. Some people have moderate symptoms, they become well. Some do not make it out. We have some markers that who is going to become sick or not sick. Old age people are going to have more features, but what is it? Is the virulence of the virus important? But when we found, and I was a part of this research, that the same virus with the same virulence, if it is affecting 100 people, not all 100 people are going to have the same symptoms. So people thought it is the viral load, but it is not also the viral load, because now it has been found that asymptomatic patients have higher viral load as compared to symptomatic patients. So if it is not the virulence, it is not the viral load, what is it? So just to make it clear, once again, let's imagine all of you who are listening me, some, let's say 10 viruses enter your body. So it can enter through your nostril. It may reside there and cause loss of your smell, or it may just mechanically enter up to the lungs. This is a mechanical entry. Why mechanical entry? You are breathing, so the virus is sucked in and it goes. Now, once it reaches the alveolar cells, so all of you know that alveoli, lungs are meant for gas exchange, and you have to breathe in. When you take in oxygen and you breathe out, you take out carbon dioxide. So along with this oxygen, these viruses entered. They entered the alveolar cell through a receptor, which I just described, through ACE2 receptor, helped by the TMPRSS2 gene. Now it has entered the alveolar cell. What it is going to do? Well, it just wants to utilize the cell to replicate, nothing more. But the problem is that it had entered very silently the cell. Now, on patrol, there were guards, and some of them suspected that something has entered the cell. These cells who are the guards, they could be macrophages, they could be macrophages. Micro means small and phage means eating. Macrophage means those who eat more. Some of these macrophages are the monocytes which have entered the tissue known as macrophage, the dendrite cells in the B cells. All these are antigen producing cells. That means if they find that the foreigner has entered, a terrorist has entered, they are going to capture it and take it to the army headquarters. Once they take it, now the virus is quietly all this time replicating. Now, as the antigen presenting cell, the macrophages, the alveolar macrophages identify it, the first task they do is to give this information to the army headquarters, the T cell lymphocyte and the B cell lymphocyte, especially the T cell lymphocytes. The T cell lymphocytes then get activated. So the macrophage wakes up the T lymphocyte then wakes up, it gets transformed and it releases cytokines. When we call cytokine storm, by this time we are very, very clear that there are some people in which cytokines will get released, some it won't. The ones which are known are going to have mild disease. The ones which are going to have increased cytokines are moderate and severe. It doesn't start in the second week. It peaks in the second week. So a lot of people thought that when you are admitted in the second week, that's the period of storm. But before that, there's a pre-storm and there is an early first week in which steroids are getting which cytokines are getting secreted. These cytokines could be TNF alpha, could be interleukin 6, and they could be WBE. Now, what do these cytokines do? They can cause endothelial dysfunction. They make you feel sick. They will cause sepsis-like syndrome. They can cause hypotension. They can cause leukocytosis. They can cause pulmonary fibrosis. They can damage your lung. So this is this. So interleukin 2, interleukin 1 beta. And just to repeat it, there are so many other diseases also in which cytokines increase. What is the difference with COVID? Now, just to repeat once again that the difference is that in case of COVID, when the macrophages, which I told you the antigen presenting cell, when it identifies that these viruses, COVID virus, what is known as SARS-CoV-2 has entered the cell, it arrests it and takes it to the army headquarters. So the initial activation of the native T cells. So it gives information to the cell. Do you have this information? Have you ever suffered from this? Has this COVID-2 ever entered your body? And so this native T cells, which is in the secondary lymphoid organs and primarily by the conventional dendritic cells, it gets activated. And this T cell lymphocytes can get activated into various. So the native T lymphocytes first will get activated. So they're CD4 and CD8. Of the CD4, of the CD4, the CD4 then gets activated into 5 kinds of cells. Please remember this, very simple: Th1, Th2, Th17, T regulatory, and T follicular. Now, these T cells may also become cytotoxic, so they are CD4 cells that kill their target. Now, what happens in COVID? The Th17 gets activated more. In other viruses, the T cells would have got activated, But the T cells, to stop the macrophage, which is getting angry and keeping on getting signals to the T lymphocytes, to calm it, it would have secreted interleukin 10. So some cytokines are there to calm down the angry macrophage so that it doesn't keep on stimulating the T cells of the body. But in case of COVID, this keeps on getting, the COVID virus doesn't stop. On the other hand, it leads to more magnification of this process. And it keeps on rising till it peaks in the second week. So the Th17, which is like an autoimmune, will keep on secreting interleukin 6, interleukin 17, interleukin 22. Whereas in situations like pregnancy, the T regulatory takes the upper hand and it suppresses the alveolar macrophage. It says, don't excite me anymore. So what is it we told? All of you, the 100 people, got the same virus. It entered the lung, but without any change in the virulence, without any change in the viral load. But some people already, their immune system, which is hyperimmune, it reacts in a different way. We call it a frustrated immune response, where the macrophage, the antigen presenting cell, which has to take the terrorist, in this case the virus, to the army headquarters, and the army headquarters being the lymph nodes where the T lymphocytes are given this information. The T lymphocytes then starts getting activated. It starts doing the research whether this virus is entering for the first time or there is a memory to it. And among the CD4 and CD8, the CD4 gets converted into Th1, Th2, Th17. In case of COVID, the Th17. So you get an autoimmune disease. So what is COVID? The virus wasn't causing the damage. It is the cytokines which cause the damage, and this damage is more like an autoimmune process. In case of asthma, the allergen would have also stimulated the CD4 T cell, but it was Th2 which would have been increased. So there is a difference between this. Now, when we have understood this, so this is all about autoimmunity. That is why even when you get rid of the virus, this autoimmune phenomenon can damage all your organs, be it thyroid, be it diabetes, be it the pancreas, be it the brain, the endothelial cells. They keep on getting damaged, and this does not stop. We really do not know why some people are so, they're frustrated alveolar macrophages, they never stop. Now, this we have known, and if it was a mild disease, you would have got well after quarantine in few days. It could be home quarantine. If you get a severe disease, you pass into an acute phase, you get admitted into an ICU. If you don't die, you are lucky, then it comes into the intermediate phase, then the recovery phase. Now, why this change? Because in some people, the macrophage got activated and the macrophage got activated the T cell, and this produced the cytokine storm. Since if there's more cytokine storm, there's more damage. And this would produce the fluid accumulation. So it is not the virus which causes the fluid accumulation, it is the cytokine. So then you have fluid accumulation, immune cell accumulation, edema, and then there is the healing by scar tissue accumulation. And you know that there are cases across the world which are just waiting for lung transplant because the entire lung has been damaged and the person has survived. So what is the clinical profile? Now, this is something which I have repeated earlier, but I again want to repeat that the symptom may start with a temperature. So you can have a temperature which is very high in the first 3 days, then it comes down, then it comes to a peak again between day 4 to day 6, then a small peak in day 10 to 12, and in a very less number of persons, the fever may still persist till about 3 weeks and beyond. But what is very, very important is that there are some features which are unique. So the first 10 to 12 days of your infection, you may have diarrhea because the cells of your intestine also, the endothelial cells also have the the um, the receptor for the spike protein of SARS-CoV-2, and these receptors are known um, as ACE2 receptors, which is again held by TMPRSS2. So you can have diarrhea. Why do you have diarrhea? It's a protective mechanism that you shed the cells, you shed the epithelium, and you bring down the virus. Why do you have temperature? Because it is believed with higher temperature, the virus replication will come down. But your body also, T lymphocytes also secretes interferon, which says to the virus that, listen, I can't allow you to replicate. Incidentally, in case of COVID, the interferons are not allowed to work. So the virus shows the thumb to the body and says, listen, even if you produce interferons, I'll not. This irritates in some people the system. Now, as I said, because of the cytokine release, there is a damage to the lung and you have to intubate. They can ARDS-like picture. Now, this ARDS picture starts as early as the last part of the first week. So a lot of people wait till the second week, and by the time they are admitted, their lung already shows that there is involvement of the lung. So as early as 4 to 6 days of the infection, there is involvement of the lung, and then this keeps on increasing. Some people, by the day 17, you are COVID negative, but please mind that even in the third week, even after you're COVID negative, the cytokine can produce a fresh damage to your lung. So just because you're COVID negative doesn't mean that your lung have escaped. This is the picture which happens. This was a profile which has been published in Lancet, and it really tells us that the story is not about 2 weeks. In some people, the story may keep on beyond a month and even longer. And this is what I would all like you to follow, that the onset of diarrhea actually is only one symptom which doesn't come back, but the involvement of the lung keeps on increasing in the last part of the first week, then it peaks in the second week, and in some people it also peaks in the third week. This has been published in the Clinical Progression and Viral Load in a Community Outbreak of Coronavirus. This published in Lancet. Now, what about pregnancy? So there was a time when we all knew that pregnancy is immunosuppressed state. Why it is immunosuppressed? Because any bacteria or any virus would have entered the cell, and your cell defense system the antigen presenting cell would have got activated the T lymphocytes, some cytokines would be released, and these cytokines would cross the placenta and would affect the fetus. So the nature, which is the biggest scientist, wants to protect the fetus at the cost of the mother. So it tells, okay, if you are going to have TB, let it, the body system is not going to fight it. You are not going to have type 4 reactions. So there can be disseminated TB in case of a pregnant mother, but there will be no fibrosis, no lung damage, because actually the body wants to protect the fetus. So when you have diabetes is an inflammatory state in which cytokines are produced. So they get magnified if you have COVID. Now, supposing a normal woman who doesn't have diabetes gets infected with COVID, what is it going to happen? Yes, the COVID virus will enter, it will replicate. The cytokines, the T lymphocytes will get activated, but instead of Th17, it is Th regulatory, which will suppress the alveolar macrophage, so very little cytokine. So most of the pregnant mothers who are not diabetes, who are not obese, who do not have toxemia of pregnancy, they will be very, very safe. You don't need to do anything. Don't create a fear in the mind of the pregnant woman. Keep her child next to her. Even if you find that there's virus in the breast milk, it is not going to infect. Even if you find that the virus in the stool, nothing will happen. Mother and child will become normal because there is very little cytokine. It is immunosuppressed. On the other hand, obesity. Please understand, truncal obesity is an inflammatory disorder. It is not just adding of fat in the truncal region. It's the inflammatory region where the cytokines are increased. So the single most important factor which can lead to death is obesity. So one good thing SARS-CoV-2 has taught, please do not have obesity, and especially truncal obesity where your legs and arms are very thin, but there's a lot of fat deposit around your belly. This actually is inflammatory, and if you're going to have SARS, it is there's going to be huge amount of cytokine which is going to be there from the first week, and it will peak in the second week, and it's very difficult to treat such cases. The third thing is, of course, diabetes. So in this case, in pregnant woman has all these risk factors, then you should be very careful. You should monitor her cytokines, and if they are high, then you have to consider that the blood sugars need to be controlled, the blood pressures need to be controlled. You have to be very careful because the baby may also get affected. So majority of the babies will have nothing, but only those mothers who have a risk factor in terms of toxemia of pregnancy, in terms of diabetes, in terms of obesity, they are going to have, because in their cases, the regulatory mechanism, T regulatory, doesn't take the upper hand. The T17 takes the upper hand, and there is going to be lymphopenia. Now, what if you give breast milk? Nothing will happen in the breast milk, even if you find a COVID virus, because there is a particular milk protein, tenascin C, which has been found, and you can understand the entire West made the mistake of saying that don't give breast milk because there is HIV virus in the milk and it can cause infection. But now scientists have identified, and this is a wonderful paper published published by Fauda, who showed that the human milk contains a glycoprotein known as tenascin, which inhibits the HIV infection. That means though there is an HIV virus, it will not allow to bind it. So the receptor site HIV and a blocking protein. So even if the virus is there, it cannot transmit it to it. The same thing applies also to COVID virus. So these 6 myths which we had there, that the viral load is related to severity, we have spoken last time also. Cytokines release in the secondary week, no. Cytokines release in the first week. And once you are negative, you need not monitor your cytokines. No, you need to monitor your cytokines. Antivirals have a role in management of COVID-19. I will come to this. Steroid dose can be fixed. It cannot be fixed because each individual will increase the cytokines according to his own immune response. Nobody knows how long these cytokines will. So there's a section of a population which even after 2 months, I had a junior colleague whose father expired a few days back, and even it was the 3rd or 4th month, but the cytokines was keep on increasing. And we really don't have an answer that why you have become COVID negative, why even after 2 months, 3 months, your cytokines. So it's kind of an autoimmune phenomenon which doesn't allow your body, your macrophages to calm down. What to do about them, how to treat them. And weakness is a common finding, but weakness has to have an etiology. Now, so what I told you, just I'll repeat it, that the SARS-CoV entered the gut epithelium, was causing diarrhea. It entered the lung epithelium through the ACE2 receptors. But in a majority of this, the antigen presenting cell, where the macrophage, they go and stimulate the T cell, and the T cell becomes the TH regulatory cell. If the TH regulatory cell it's increased, then it will increase the natural killer cell and the B cell. And there's interleukin 10, which then stops. But in few, there's a hyperinflammation. So COVID doesn't want immunity, it still is a hyperimmunity. And there could be some age factors like smoking, diabetes, and such things. So there's written glucocorticoids, but now it has been found that glucocorticoids actually protect you. So those patients who had rheumatoid arthritis and were on glucocorticoids or were immunosuppressant, when they had COVID, they had very little symptoms. Because in these, the macrophages then activate the T cell, which activates the IL-6, TNF-alpha, GM cell, which causes the damage. So You will find that IL-6 is also increased in bacterial infection. So sometimes people think IL-6 only increases in case of COVID. No, no, no. It also increases in bacterial infections. And so you have to rule out that there can be coexisting bacterial infection which needs to be treated. So what is it that I'm trying to say? That I'm trying to say that those of you who had COVID and had no symptoms, they are the pulmonary epithelium cells, the COVID virus entered, but your CD4 T cells and your CD8 T cells, your lymphocyte population was good. It didn't decrease. No cytokines was released, so no symptoms. What about those who had moderate cases? In here, the COVID virus entered, and your body immune system was midway. It didn't cause a severe, but it increased the cytokine levels. So you had pain, you had fever. Your CD4 got the CD4 got activated. So actually the CD4 and the CD8, the T lymphocyte count decreases, the IL-6 increases, and the TNF alpha increases. In fact, the IL-10 may become. So this cytokine levels now causes damage, and you have fever, cough, fatigue, myalgia, and lymphopenia, which is because both the T lymphocyte and the B lymphocyte decrease, but mostly the T lymphocytes and both the CD4 T cells and the CD8 T cells and the natural killer cells. And also the interferon producing expressing cells are markedly decreased. So in severe COVID and moderate COVID, the only difference is that here the cytokines increase more. The cytokines are not only IL-6, but is also IL-10 and TNF alpha, and the total T lymphocytes really become very less. And so what you do when you do your test with LDH, it is high, D-dimer, it is high, procalcitonin, it could be high, CRP is very high, and interleukin-10 and TNF alpha. So all these so-called cytokines are very, very high, and this causes pulmonary damage, respiratory disease, and unfavorable outcome. So don't fear the virus. It is the response of your body which makes you mild, moderate to severe. Now I come to the most essential part, which I have not discussed it earlier. How would you manage it? What is new in the last couple of months which we have learned? Are there evidences to support it? Are there evidences? What is the take-home messages? So up till now, the take-home messages, which was a part of my last lecture, was that it is not the virus which determines that whether you are going to have mild, moderate, or severe. It is your own body immune response. It is not the virus which causes the lung damage. It is your body immune response. It is the cytokine response which starts rising in the first week, peaks in the second week. Even when you become viral negative, it will keep on increasing. In some population, it may peak in the third week. Now, how do we treat it? So what is the way we are treated? So there's multiple drugs. So most important was antiviral drugs. And some of you believe in antivirals because, yes, it is a viral infection. So I have a drug which can kill these viruses. So I'll escape. Now, please understand the antivirals which have been used, remdesivir, lopinavir, ritonavir, and all other HIV protease inhibitors, these drugs, how do they act? So as I told you, that the virus has to enter through angiotensin converting enzyme 2 receptor, which was there on the alveolar cell or on any cell. So this drug, first it inhibits the viral entry through the ACE2 receptor. Then it doesn't allow the transmembrane serine protease 2, that is TMPRSS2, to get activated. Then it doesn't allow the viral membrane fusion and endocytosis. It doesn't allow the activity of 3-chymotrypsin-like protease and the RNA-dependent RNA polymerase. So this is how the antiviral will act. So you can ask me, if this is so, why don't we give antivirals? Now here I would like again you to go back to this. The virus just activated the T cell. The virus in fact activated the macrophages, and the macrophages activated the T cell, and the T cell secreted the cytokines. If the cytokines are not secreted, you are not going to have symptoms. So if you had to give antivirals, the greatest impact would be when it is given very, very early, before the virus has the capability of stimulating the alveolar macrophage. Now, most of the time, we realize that we are infected on day one of the symptoms, where we have spread this infection to all our household members. The maximum spread has already caused, and then the maximum spread will be over by day 7. But so the total spread will be over by day 7. The maximum spread happens within 24 to 48 hours, either prior or just after you get infection. So once the antivirals have stimulated the alveolar macrophage, then the antivirals have no role, because now it is the story of cytokines. Some scientists believed that the cytokines actually rise in the second week. Now that's a myth. I have my own data and I have data of so many other people that if you start doing it from D1, the cytokines rise along the first week, peaking in the end of the first week, rising, and then it really goes sky high in the second week and coming down by the second week. Once the cytokines are released, then you have to have an anti-inflammatory diet. So perhaps the antivirals are not going to be very effective. And it is very difficult to get any person on day 1 or even before day 1 to give antivirals. So whatever use it is, by the time you come to the hospital, I don't think antivirals have a major role, because you get admitted to the hospital because your saturations have fallen, which is an effect of cytokines and not the virus. You have respiratory problems, or you have very high fever, or you have myalgia. All these features are a product of cytokines and not the virus. So for a second week, if I'm admitted, I don't think there's a huge gain by giving antivirals, even if I give it on the day 1 itself. People tried anti-inflammatory to stop the cytokines. The most important is, of course, the steroids, because as I told you, Th17 is an autoimmune phenomenon. It releases all kind of autoimmune disease. So the way you treat rheumatoid arthritis, the way you treat all kinds of autoimmune diseases, you treat it the same way through the steroids. There are other drugs which are IL-6 inhibitors, like anakinra. They have been tried, but as I told you, there are more than one cytokines. So some studies showed benefit, some studies didn't show benefit to that extent. But overall, there was benefit. And then people also gave anticoagulants and fibrinolytic with variable success. Now, this is a very good visual summary of the recommendations by WHO guideline on COVID-19. What does it tell you? Now, this is a population, patients with confirmed COVID-19. So the non-severe are not going to have any signs. So what are the signs? You're not going to have prolonged fever. You're not going to have prolonged myalgia. You're not going to have respiratory distress. You're not going to have oxygen saturation fall. Then you become mild, moderate, and then severe. When severe, on room air, remember room air has the fraction, oxygen is about 21%, and on room air, if your SpO2 is less than 90%, you classify in severe, or you have a respiratory rate of more than 30 in adults, or you have signs of severe respiratory distress. And you're critical when you require life-sustaining treatment, or you have sepsis or a septic shock. So what is the treatment? Now, among the interventions, there were 2 interventions. One was remdesivir. And even WHO now has admitted that this recommendation is very, very weak. And the pathophysiology I just explained to you, because if the antiviral had to enter, today if your virus has entered the body and I give you an antiviral, maybe it can stop. But once your immune system has been stimulated, the cytokines started releasing, the antivirals will not have any role. The corticosteroids, they have got recommendation, but the problem is that the recommendation is strong in the second week and not in the first week. Now, this also I will question. This is our WHO recommendation. Now, what made them give this recommendation? There were two papers which are very important. One was published in NEJM in May 20, where they compared giving remdesivir to a placebo, and they found that at best what remdesivir does that it decreases the stay in the hospital by a few days. But even they found that remdesivir was less effective in sicker COVID-19 patients. So actually those patients who required ICU care, remdesivir was not at all, because then it had no role. It was the cytokines. So those who are on ventilator, those who are on requiring oxygen, it didn't carry much sense to give these antivirals. But after that, there was another study which is known as the WHO Solidarity Study, and I'm also quoting the UK study, in which they found that dexamethasone was very, very effective. But the WHO Solidarity trial found that remdesivir has not significantly reduced the risk of death or even shortened the length of the hospitalization. Now, this was a study which was done across the world in various countries, and this was a very, very powerful study in terms of its planning. So the article which was published way back in May 2020, where the least evidence was that it may decrease the stay for a few days, even that was questioned. So I really do not know whether in hospital we should be giving these antivirals at all or not. So the current guidelines is there's no evidence that it improves survival and other important measures. And this antiviral drug is not suggested for patients admitted to hospitals with COVID-19, regardless of how severely ill they are, because there's currently no evidence that it improves survival or the stay or the need for ventilation. This is part of the BMJ publication. And if you are giving, of course, you know that you give 200 milligram on the first day and then for another 5 to 10 days again. Now, again, I'm trying to tell you there could be few cases where the virus is keeping on replicating. That will be a very, very few cases. So I did find in the literature 1 or 2 cases where they found that in the 3rd admission, 4th admission, some people gave remdesivir. And this is not very clear because it doesn't explain your pathophysiology. Now, what does corticosteroid do? So the most important trial which came out from UK, they found that giving antivirals, giving all these drugs were not of much use. Anti-inflammatory was very used, and corticosteroids. So how would it act? So broadly speaking, it will reduce the number of apoptosis. It will act on the eosinophil on the T lymphocyte. So the T lymphocyte will calm down. There will be less cytokines. There will be less mast cells. There will be less macrophages. There will be less dendritic cell stimulation. So the cytokine will, on the other hand, it will act on the epithelial cells. It will decrease the cytokine mediators. It will act on the endothelial cell, and it will prevent the leakage, and it will act on the smooth muscles and mucous glands, so less mucus secretion, etc. And if you see the macrophage, which is going to stimulate the T cells and the dendritic cells, which are going to become the Th1, Th2. So the corticosteroid overall suppresses the cytokines, and this is the mechanism. I will not go into details, but you can refer to this slide later on, how the corticosteroid is actually causing the apoptosis of the macrophages, decreasing the IL-1 beta, decreasing the INF alpha, decreasing the IL-6. And so some people suggested, and this is where my second part of the question is coming, that okay, steroid has to be given in second week, but in case I have demonstrated that my cytokines is high in the first week, why not give it? Now, WHO answers this that because majority of the people, this was based on the recovery trial, which was done in UK, where it showed that giving dexamethasone for 10 days really suppressed the cytokines, and the patient improved. They didn't go on to the ventilator, but this was not done a field study. Now, if you apply the same mechanism in 100 people, and I start doing the cytokines on day 1, day 2, so at let's say day 8th of the life, the CRP is 150, but it didn't go to 150 on one day. So maybe on day 3 it was 20, maybe day 9 it was, day 7 it was 70. So if I had given the steroid early, I would have suppressed this peak. So what it means that not everyone would require steroid, but if you are going to know that the cytokines are high, then the cytokines needs to be suppressed early so that your storm is not so high, it doesn't peak so high. So this is what I was telling. And now I would again reiterate that please do. Now the problem of the lab is that the government labs do not do IL-6, and across the country, even the capital of Delhi is making a kill. They charge you 5,000 rupees for doing the cytokines, especially the IL-6. Friends, this is a challenge we can set up at much lower rate. It will just cost you some 200 rupees. But in case you can't get the IL-6, anyone who has prolonged fever, anyone who has got myalgia beyond 48 hours, you can be almost betting that his or her cytokines will become high. But in case you have diabetes, then the problem is that the symptoms of the cytokines, for some reason, is not so clear. So if you have a diabetic patient, which is uncontrolled diabetes, and on the top of it you have COVID, then somehow the features of early features of pain in the body, myalgia, all this is very less. So patients, they come to the hospital late, and actually this is a very, very dangerous thing. So I would say that first the country should try to get the cytokines done. But in case if you do not get the cytokines done, then the next best process is do 5 things. Measure the temperature. If the temperature for another 2-3 days is more than 100, then you think your cytokines are high. Measure the blood pressures. If the blood pressures are low, not high, low, then your cytokines are high. If you find that your blood sugars have suddenly shot up, then your cytokines are high. If you are going to have muscle pain, then your cytokines are high. If you have nausea, vomiting, anorexia, then your cytokines are high. So they can be very simple procedures, having a digital thermometer, having a blood pressure equipment, and also use pulse oximetry. So not only see the saturation, see also the heart rate. A lot of people only depend on the saturation. My saturation is 96, but your heart rate is more than 100. That means your body is trying to compensate for it. That's not a very good phenomenon. So both see the heart rate. So the same instrument, you get both the heart rate as well as the saturation. So some people said, okay, 93 is acceptable. 93 is acceptable if your heart rate is less. But if your heart rate is more, I would not accept 93. I would like to keep your saturations much higher. So drop in saturation is another mechanism. Now people got confused. Okay, you have to give steroid. Which steroid to give? Okay, the recovery trial showed dexamethasone. The solidity trial didn't, of course, go for this. They only showed that antiviral doesn't work. Why can't we give hydrocortisone? Why can't we give methylprednisolone? Why we not give prednisolone? I tried this. Still now in the literature, it is not very clearly substituted. But let me tell you, and this is my personal experience, the experience of majority of the people, that if your lungs are really affected, the most powerful corticosteroid is dexamethasone. The second powerful is methylprednisolone. The third is prednisolone, and the fourth is hydrocortisone. The patients I took, and including my case, I found that the cytokines are not actually suppressed by hydrocortisone, even if you increase the dose. So 6 milligram of dexamethasone will become 50 milligram of hydrocortisone, but even that will not have the same value in terms of inflammation. And that is why the anti-inflammatory property of dexamethasone is 25 times that of cortisol, and the property of methylprednisolone is 5 times that of cortisol, and prednisolone is only 4 times. So you can see the dexamethasone has got a longer action as compared both dexa and meta of 24 to 48 hours, and even up to 3 days, whereas methylprednisolone is 5 times in terms of anti-inflammatory. It has got a shorter duration of action. So that we know. And the sodium retaining potency is absolutely nothing in DEXA, but it has got in methylprednisolone. So what are we trying to say? We are trying to say that if you have to use a steroid, it's better to use dexamethasone or methylprednisolone. But again, what dose to be given? Now, this is a wonderful study which AIMS Bhopal published it after I had given you the first lecture. So when I talked to them, they said, sir, we are studying, and they have just published their work. And their question was whether giving early steroid dose is associated with lower mortality in COVID-19 critically ill patients, a retrospective chart review. Now, this is a very, very important study, and I quote it because the last time when I was talking under the banner of Association of Health Service Doctors, the study was not there. So just to remind you, the hallmark of COVID-19 associated severe disease is increased cytokines, which means CRP and the D-dimer, the IL-6, the ferritin. And we all know in the second week there is a peaking which is known as the cytokine storm syndrome, which is going to produce the ARDS and pneumonia and some problem in the coagulation pathway. Now, how to say that you are severe or not? Now, some people will say, okay, oxygen saturation, but there's much better mechanism of saying that how severe you are. And this is PaO2 and FiO2. Those who are not from medicine background, let me explain you what is PaO2. So when you breathe in oxygen. This oxygen is going to your blood. Now, in the blood, you have the white component, which is the plasma, and the red component, which is the red blood cells, which of course contain the iron, and that's what provides it red. Now, the red blood cells have the hemoglobin. So first, the oxygen, 97% of your oxygen is carried by the hemoglobin, and 1 gram of hemoglobin carries 1.34 ml of oxygen. So 97% is carried by your hemoglobin. And how do you measure that? So you measure that by doing the oxygen saturation. That means of your hemoglobin, how much is saturated. If it is 100, that means all your hemoglobin molecules are saturated. Each one of them is carrying 1.34 ml. Now, the rest of the oxygen is dissolved in the plasma, and this follows the Henry's law. That means you apply more partial pressure, more it will be dissolved. And how much will it dissolve? So for each 1 millimeter of mercury, the pressure of 1 millimeter of mercury will dissolve 0.003 ml of oxygen in 1 deciliter or 100 ml of blood. Now, so the PaO2 you measure through a blood gas. So when you measure in the blood gas, you do not measure, you measure the oxygen in the plasma, and the one which is in the hemoglobin is measured by the SpO2. Now, if the PaO2 FiO2 ratio is very high, that means it is good. Supposing I have a PaO2 of, let's say, 90, and I'm in room air, that means FiO2 is 0.2, then of course my PaO2 FiO2 ratio is more than 300. The normal would be 400 to 500. So this is also known as Horowitz index or Carico index, and this is very, very important. So just to tell you that the air which you were breathing had an atmospheric pressure, and the atmospheric pressure, when it was going in, your oxygen pressures were 150 millimeter of mercury. By the time it reached the alveoli, it was 100 millimeter, and by the time it got dissolved in your plasma, it was 90 millimeter of mercury. So the amount of oxygen in the blood is calculated using the formula, that one which is carried by the hemoglobin, and this you measure through pulse oximetry. And all of you know that the pulse oximetry saturations are so important. And the second, you can do a ABG, and in the ABG you measure the PaO2, and it depends upon 0.003 into the pressure which is there. So if the value is less than 300, it is, if it is less than 100, it is very severe. 100 to 200, it is moderate, and less than 300 is mild. So if you have a value, so I got admitted on day 1, and my PA2 and FI2 ratio was more than 400. What does it mean? It means most likely my PO2 was 65, and in room air, so at a PO2 of 65 at 0.2, you'll get a value of more than 300. That's what it is showing. So when they did the study with the PO2 and FiO2, they found that if they give early high steroids, 15 people survived and 7 died. Where if they gave early low steroid, 8 people survived and 3 died. So if you give early, both high and low, more people were surviving as compared to if you give late steroids. Only 3 people survived and 9 died. So you can say that giving early, high or low, and I'll come, because this high and low is not decided by it's decided by the patient's condition. But if you are giving late steroids means in the second week, then there is more chance of death as compared to giving early steroids. So this was one of their work which was there. And if you are giving very low dose steroid, that is inappropriate steroid, there were more deaths. But if you're giving appropriate steroid, so this is a wonderful work done by AIIMS Bhopal, where they found that giving early dose steroids improved the survival, and if you gave appropriate dose steroids, it improved. And this is what they showed. So they showed, so this is the orange color is the death, and the green color is the survival. So if you give appropriate dose, they are going to be more survival, that the green is more than as compared to the other one. Both if you are very severe versus less severe. Even if you have an infection and you give appropriate dose of steroid, there will be more survival, as if you stop the steroid saying that you have infection, there is going to be more deaths. So this is again both in infected and sterile. And even if you divide by age, less than 60 also, if you give appropriate, there was more survival, and even more than 60 it was. So what do we, even in diabetic people, it was more. So what is it said that you should give appropriate dose steroid, you should give it early. Now let me, before I finish, let me just tell you about few patients. So this was a 68-year-old patient. He was Sister Priyanka, who's working with me. The father, she had heard my lecture. He presented with fever for 2 days on 18th and 19th November, malaise for 5 days. So remember, he's 68-year-old, is breathless for 1 day. There's a family history of contact. Wife was having fever since 15th. Here contact means COVID. And son had fever and leukopenia on 17th to 19th November. Investigated and found COVID positive on 22nd. So 70-year-old, remember, having also breathlessness on 19th of November. Now, what is the course of illness? So on day 1, the fever was 2 days. There was a general malaise, and then the slide has been prepared by my resident, so she writes, discussed with Arun sir. Anyway, so COVID-19 PCR sent, CRP, D-dimer sent, monitor clinical well, and etc. And we breathlessness and desaturation. So the CRP was found to be 185. The D-dimer was 0.7, and there was clinical worsening. So they didn't get admitted. They were at home, and they started injection dexamethasone 4 milligram IV twice daily and Budicort inhaler, and repeated CRP and CT chest. So the initial CT score as early as day 8, even before you are admitted, was showing 15/25. COVID report positive. Then admitted after this on day 8, given injection Dexa 2 milligram BD, injection remdesivir. We couldn't stop this. And I mean, this is the protocol here, but we had given early. The CRP now became 29.9, the D-dimer. Now here is what I am giving to tell you. Why do we want to give remdesivir? Because already once you gave steroid, the anti-inflammatory, the CRP D-dimer would have come down, and it actually came down. And the blood sugars shot up, and you had to give it. And by day 12, he was discharged on home-based care. So oral methylprednisolone tapered every 5 days, malaise persisting but improving. CT got cleared, no recurrence of symptom on day 30, minimal malaise on tapering steroid. So even till 30 days. So we don't follow the principle of the recommendation of WHO, only give it for 10 days and you can stop, and that to very severe patient in second week. So another patient, 78-year-old, onset second day, became COVID positive, course of illness, fever for 1 day, generalized malaise. Okay, started on Predmet as early as on day 1. It was a telecommunication, so it was continued, and the CRP was 16.9, D-dimer was 1.1, reported COVID negative, CRP 4.3, D-dimer 0.9, tapered. So I can show you a lot of patients who were treated, and if you see the lymphocyte count, they can improve after giving steroids. So you see between 23rd and 27th, the lymphocyte count increased from 10 to 23%. So I end here by saying that 3-4 things. In Calcutta, there are a lot of patients who are having very high fever and very severe malaise. And if you are young, you will have very severe rash. And if you do the CRPs, they are very high, and they are also very high interleukin-6. I know a few days back of a professor of urology who rang me up to say that he had heard my lecture, and he said, what do I do? Now, if you have rash and you have joint pain, these are not COVID, these are very similar to chikungunya, which is rampant in North Calcutta. A lot of patients are coming, and here also steroids are working. The second thing is, what is the role of metformin? Now, initially, people were giving metformin only for treating diabetes patients. But when I looked into the literature, I found that metformin can also stop the cytokines to act. Now, see what is happening in COVID. Some of these cytokines were going to the pancreatic islet cells and were actually was causing the dysfunction of the insulin release and was causing the blood sugars to go very high, and to top of it if you are giving steroid. But when you give metformin, metformin prevents the cytokines to act. There's a beautiful 3 papers. So if you just Google search the role of metformin on cytokines, you'll get very beautiful papers to show. So I would tell you that you give insulin, but also give metformin, because metformin stops the cytokine to act on the islet cells, and your requirement of insulin will come down. Your blood sugars will be much more controlled. So the first point I would like to say, please use metformin as an anti-cytokine substance also, especially in cases of COVID and your blood sugars are high. The second thing is Perfinex. Perfinex was used to prevent antifibrotic, but Perfinex is also a drug which prevents cytokines to act very early and cause a lung damage. So I think there's a role of giving Perfinex very early when your lungs are involved and when you are finding your cytokines are very high. The third thing is, a lot of people from COVID, they suffer from weakness. Long time I was suffering, and they have low sodium values and high potassium values. I was studying these cases and I was not able to understand, but I suspected that the hypothalamic pituitary adrenal axis is getting affected. And now there are 5 papers which show that actually, even when you do autopsy, there's adrenal hemorrhage. And they have shown that the cortisol secretion from the adrenal cortex actually drops down in cases of COVID patient, and that is why you feel weak. Why do you feel fresh in the morning? You feel fresh in the morning because your cortisol gets released at 8 a.m. in the morning, and so you feel fresh. Why do you feel tired in the night? Because by this time your cycle, your night-day cycle, circadian rhythm, the steroid secretion is low. So this is one. Second thing is, I suspect is that the mineralocorticoid property is also getting affected, and you find that there are low sodium and high potassium, even when you are giving insulin. So this area requires much more research, and if you find that there's electrolyte imbalance, you can give fluorocortisone. Now, When you give steroid, how long to give steroid? We don't have an answer because it all depends upon your cytokines. And even I had to take it for 6 weeks. I think there's some people where it continues beyond 2-3 months. At least reasonably would be you should follow it at least till 2 months to see that the cytokines don't come back again. Sometimes you become COVID negative, you are discharged by giving 10 days of steroid, and you go home thinking, now I'm COVID negative, and suddenly you develop a lot of symptoms. And then when you do your cytokines, they all become very high, and this can cause damage, and you may die out of this. So what you call the post-COVID patients, I beg to differ. It is a continuum of the same problem. You were getting RT-PCR positive and RT-PCR negative, but the disease pattern doesn't stop with COVID, especially in moderate and severe patients. The disease pattern is that the activated macrophages may continue to remain active for a pretty long time. The third thing is we are not using physiotherapy. Now, when you use steroid, and even when you're a patient to lie down, I think one of the things which should come, we should involve the physiotherapists, both for lung physiotherapy as well as for because if you lie down, there's a wasting of the muscles, and you require physiotherapy to act. So I would request that as doctors, please spread this word that you require also a physiotherapy both for lungs and also for walking, and very slowly you have to put back the person in, and you have to monitor the cytokines. So what is new from my last lecture? The last lecture, I didn't know that the role of both Parfinix as well as metformin is also anti-inflammatory and anti-cytokine. The third thing is that there's still a question how long to give. You have to maintain the cytokines and to do the clinical features. The last thing is that now I am pretty convinced that if you have to give antiviral, it doesn't work in the second week when you get admitted. So you could save that money, and you could try setting up a laboratory where cytokines can be done. There should not be any COVID phobia because, and please understand, obesity is single most important reason. And as a community, my message is increase your nursing staff, train them well, you're going to get. For those who wear masks, let me tell you, don't apply newborns, children less than 5 years, any mask. Don't apply mask to those mentally retarded children or anyone in your family who cannot remove the mask. Don't wear a mask if you are having respiratory distress. And try to use a simple surgical mask, because if you wear a mask which is going to create a lot of resistance during expiry of air, this can actually lead to extra load on your lung and can cause infection. So when you're climbing stairs, you're running, or you're doing some very active thing and wearing a mask, take morning air, do morning exercise, keep your windows open, don't be in AC, and remember, air conditioning, centralized air conditioning can be a source of infection. So thank you very much. Any questions, I'll be very, I'll be able to answer them. I'll try to answer them. Yes. Am I audible? Am I audible? Yes, Dr. Avik, if there's any question, please let me know. Can you hear me? Dr. Avik?
Yes. Thank you, sir, for such a beautiful presentation. You have covered all the aspects of this COVID-19 pandemic. Okay, sir. One person is, I think you have covered this part. Yes, sir. Can you hear me, sir? Am I?
You are very much audible, Dr. Avik. Please go ahead.
Okay, sir. One person has asked about the course of disease in people taking steroid. I think you have already covered it. We should move to the next question. The role of ivermectin.
So WHO has really
One person has
has
asked about the role of ivermectin.
about the role of, yes, Dr. Avik, role of,
Role of ivermectin.
okay. So I would say
Ivermectin.
that, yeah. So the only study which has been properly done in India was by AIMS Bhubaneswar, where they have used ivermectin to stop the spread. So they found 18 milligram of ivermectin on day 1 and repeat dose after day 3 brings down the infectivity. So if I'm COVID-19, suffering from COVID-19, I'm suffering from SARS-CoV-2, then by giving this to other members who are close to me, there's a 40% reduction in the infection. But once I have the infection, I don't think ivermectin has a huge role.
Thank you, sir. Sir, I have a personal question. Being a
Yeah, please.
gynecologist, I want to ask you that what is the that have you seen any cases of transmission of virus from mother to fetus, or there are any I mean the congenital abnormalities due to this coronavirus? Have you seen have you seen any
Okay.
such cases?
Okay. So thank you, Dr. Avik. You have asked a very pertinent question. This is my area of research. We are shortly going to publish our works. So your first question first. Does COVID virus cause any fetal anomalies? The answer is no. We didn't get it, and I have tested the literature that it doesn't do it. Now, the second question is, you don't need to separate the mother and the child. If the mother, even if the mother's breast milk, we have isolated COVID virus in the breast milk, we have isolated COVID virus even in the in the stool of the child. My only request is that both the mother and the child are immunosuppressed. They will have a viral infection with no symptoms. And we have now got 200 cases where we found that they become negative very soon. And it doesn't transmit to the breast milk. It doesn't. So please do not stop breastfeeding. Keep the mother and child diet together. We have done this. We gave this recommendation based on our study to Government of India. The Government of India is also following it. Only thing is, which mothers will have problems with their children? Only those mothers who are sick. So basic message is if you have a sick mother who has eclampsia of pregnancy, because this is the stage where cytokines will be high, if she has a moribund obesity, if she has diabetes, these are the mothers that if they get COVID, they will have a lot of features. And in that case, there will be no anomaly of the fetus, but you will expect that the fetus will also be symptomatic, not because of the virus, but because the cytokine will cross the placental barrier and will cause the problem.
Okay, sir. Thank you. Sir, do you think that we should apply, we should recommend universal test for pregnant mother regarding this COVID-19?
Very good.
I mean the antibody
Yeah.
test, RT-PCR,
Yeah.
or
So
the
Avik, yeah, I got your question.
antigen
I got your question.
test.
Yeah. So Avik, I got your question. When we test the mother, we don't test it
Should
for
we
her.
routinely test all the pregnant mothers, or there is no need for doing so?
Okay. So the question is, why were you testing it? You were not testing it for the mother, because the mothers usually have no symptoms. And the mothers will not do any, neither the mother nor the child will have any problem even if they have COVID. We were doing the test for our safety, not for the mothers and child safety. They are safe because, as I told you, that the immunoregulatory cells is very active. Unless until they have diabetes, she had a stormy courts during antenatal period, then there is a problem. See, routine testing was done because the doctors were thinking, the nurses were thinking that without knowing the status, we can get infected. Surprisingly, in a country of about 100 million, already 1 million are known to be positive. And I can bet that for every one person, there will be 100 persons who either were asymptomatic, or even if they were symptomatic, they never got it tested. So I think that this is a policy which was for the safety of the health personnel and not for the mother and the child. So I will leave it that if you are a brave person, like I have already developed COVID, I do not wear any mask. I can go. But in case you have, you think that no, getting COVID is going to be dangerous to me, I am above the age of 60, I am diabetic, I have other problems, then it may merit that you get the mother tested. Yes. Yeah, Avik. Am I audible? Am I audible? Dr. Avik, am I audible? I think I can't hear him. Let me call the organizers and know whether. Yes, Dr. Sandeep, you can use steroid, metformin, Parfinix together. Let me tell you, my learning with metformin was huge. Search the literature. Metformin and Parfinix both, especially if you have deranged blood sugar, it can have an anti-cytokine. So I would say use metformin if you find that your blood sugars are on the higher side, especially when you are using steroids. It is questionable. You may say that, well, my sugars are normal, why should I use metformin? Of course, metformin doesn't cause. That is something which, but people think about lactic acidosis. I think that's a very far-fetched. You should use metformin even among the aged. So there can be a situation where I have used all the three: steroid, metformin, and Parfinix. Yes. Any other questions?
হ্যাঁ হ্যালো
হ্যাঁ, শোনা যাচ্ছে আমাকে?
হ্যাঁ শোনা যাচ্ছে। ওই মুভি কেটে গেছে, ওর ওর কিছু একটা নেটের প্রবলেম হয়েছে। ওর কোশ্চেন গুলো যেন প্লেস করতে পারছে না।
আচ্ছা, তো তোমরা কেউ প্লেস করে দাও।
না, কিন্তু কিছু একটা প্রবলেম হচ্ছে স্ক্রিনটাতে। আর কোশ্চেন আছে, একটা কোশ্চেন ছিল ভিটামিন সি জিঙ্ক রিকোয়ার্ড কিনা।
Okay, so someone has asked whether vitamin C or zinc has to be given or not. I would say that all vitamins are welcome, especially in case of septic shock. People have found that vitamin C has a role. So if you are very severely, you can give, but that is not up to the 6 grams. Someone I was finding, or some doctor had posted a message that 6 gram, I would not ask you to take. So vitamin C has a role when you are in a shock. Generally, you should eat fruits which contain natural vitamin C. Regarding zinc, if you are zinc deficient, then it will help your body, but they are not going to act on the cytokines, and they are not going to change the scenario, especially in moderate to severe patients. So at best, they can be adjunct. They can't be the main actor. They can be side actors. So there's no harm taking vitamin D and zinc and vitamin C. I will not go because, but they are not the main drugs which will help you. Any other questions? Let me see if I can. open the.
একজন কোয়েশ্চেন করেছে স্টেরয়েড মেটফর্মিন পারফিনেক্স ক্যান বি ইউজ সাইমালটেনিয়াসলি ইয়েস অর নো?
Yes, you can use it. You can use it simultaneously.
আচ্ছা, নেক্সট কোয়েশ্চেন হচ্ছে what should be the duration of the therapy for steroids and can it be started empirically?
Well, you see, in a scientific way, I cannot say yes, but if you have a scenario where nothing exists, you can't do the cytokine test, then you may think. In fact, that is what is happening in the countryside. People are starting very early steroids empirically. To the question which was earlier, what was the earlier question? How long to be given? Now, how long to be given will depend upon
Duration of
will
steroid
depend
therapy.
upon your body cytokines. It is your body which determines. So if your cytokines are very high, they continue to be high, you need to suppress them. The role of chemoprophylaxis against COVID. If I understand what were we saying, we are saying other chemo drugs which are immunosuppressive, if you give that. Is that the question, Dr. Chatterjee?
Next
Achha, there's
question
another-
is
what kind of anticoagulant drug do you prefer? Well,
right.
when you are in the hospital, I would prefer low molecular weight heparin. But once you are outside, choose any cheaper variety of anticoagulants. Some of them are very costly. They don't make a huge difference. But initially, when you are very sick, you are in the ICU or you are requiring high levels of oxygen, it is always to give low molecular weight heparin. Yeah, you were asking something, a question, yes.
The next question can be seen in the screen. What should be the course of anticoagulant?
What should be the course of anticoagulant? Very good. So you see, let's say if your hospital stay is 7 to 10 days, you give low molecular weight heparin, you shift to oral anticoagulants, but don't give aspirin along with it. Sometimes that creates a problem. Be very careful. Know your platelet levels also when you're giving aspirin, because some of the patients would be taking aspirin from before. The course is that you give it at least oral anticoagulant if a person has suffered from moderate to severe for 6 weeks. If you haven't, there's no role. And you can see your D dimers. But remember here, the D dimer is a marker of acute inflammatory reaction and not a marker of consumptive coagulopathy in which the fibrinogen level is low. I just forgot to tell you one thing. All of the doctors must appreciate that that COVID-19 is SARS-CoV-2 is a virus, and you require an electron microscope to see all viruses. And just to tell you, the first electron microscope was made in Germany in the year 1930. It was commissioned in 1938. But the first electron microscope in Asia, can anyone say where was it made and who made it? And when was it made? The first electron microscope of Asia came in Calcutta as early as 1948. And I would request the doctors to find out the name. It has got a connection with Saha Institute, and get a picture of the original electron microscope, which is there as early as 1948, and it was used for viral studies. Yes. You had a question.
The next question is why the incidence of COVID and its severity is less in children?
Very good question. See, I told you the whole process. So when you say the numbers, children are equally susceptible to COVID infection. So this is a myth that they have less receptors and etc. What is happening is that they are asymptomatic. Why they are asymptomatic? Because symptoms are produced by cytokines. Now they have an immunosuppressed state, and secondly, for some strange reason, the activated macrophage, the angry macrophage, is not so angry in children. This was found also in SARS-CoV-1 in 2002 and also SARS-CoV-2 in 2019 and 20. So somehow the cytokine production of children is not so much. I believe it's like an old tree. If you cut a tree, you find rings, and the rings tell you the number of years. So if you go to the botanical garden and find a tree which is 150, 200 years old, it will have 200 rings. Now, the year where there is a famine, say 1945, there was a man-made famine in Bengal, that year the ring will be distorted. So there's a genomic signature of all the infections we have suffered. So I personally think that we have, in our course of life, suffered from various infections, which in some way is further activated by the macrophage. This mechanism is not clear, but there's some genomic signature which is left over. Yes. Is aspirin or clopidogrel useful? Aspirin is not useful. Please be very careful for the platelet levels. If you are using clopidogrel, you can continue to it. But if you have suffered from moderate to severe COVID infection and have taken low molecular weight heparin, then it is better to take the regular oral anticoagulants which are being used. Where body immune system is working in an exaggerated way, what's the role of vitamin C and zinc? So you have asked me the right question. Early, when I was not reading much about this, people were saying that if you had good immunity, you would not suffer from COVID, or you would not suffer. So it is the hyperimmune response. So there's hardly any role of vitamin C and zinc. But yes, if you are deficient in vitamin C and zinc, it may have a role. Or if you are in shock, then high dose of vitamin C has a role. If you see, there are guidelines to use vitamin C in septic shock IV. So let me know the duration of dexamethasone. So I would say use dexamethasone only when methylprednisolone is not working. Keep that. And what is the duration? Well, it all depends upon your cytokines. So if your HSCRP was 150 and it has become less than 2, you can slowly come down in steps. And after you have stopped, again measure your cytokines. If it goes back, that means your body required steroids for a longer period of time. Why diabetic patients have more cytokine storm? Very good question. Dr. Dibendu, I think that all diabetes, obesity, toxemia of pregnancy, all these cases are actually inflammatory disorder, and they're chronic inflammatory disorder. And why there is inflammation? Because there is something released from the cell. So that classical dolor, rubor, pallor, whatever we read for inflammation, that is produced by cytokines. There can be different cytokines, but different. So already the diabetic patients have high cytokines, which are further gets amplified by COVID-19. Yes. Which investigation should be done before application of? I would say that first of all, when you are using this injection, enoxaparin, perin, you should have a high D dimer. You should do also fibrinogen level, and you should do your platelet level, and do your PT and APTT. You should differentiate from a consumptive coagulopathy to an acute phase reactance. Consumptive coagulopathy, where there's more chance of embolism, there the role of this injection is far more. But in case of acute inflammatory disorder, the role of steroids is far more. So how frequent should one measure oxygen saturation level, as many are showing happy hypoxemic phase? Yes. Please understand the mechanism. It is nothing happy and nothing. So I did the blood gas of almost all the patients who were suffering severely in the ICU. So the one answer, let me tell you, if you do your blood gas, I think someone's phone is on. I mean, it is reverberating. Is it mine is on? No. Can someone put off your phone so that it? So the reason is that, please understand that if you do the blood gases of severe COVID patients, they will have very low PaO2, they will have very low SpO2, but their pH will be normal. Their lactates are normal. That means that the oxygen required by your cell is determined by the mitochondria. And let me tell you, though the PaO2 is 80 to 90, the mitochondrial oxygen requirement is less than 5. Less than 5. So somehow in COVID, the cells are not they are still going aerobic respiration and not anaerobic respiration. So lactates are not high. The TCA cycle is not utilized. So you don't have metabolic acidosis. So that is why they are happy. Now, my understanding goes, and this is the understanding of most of the people, that your oxygen saturation doesn't fall because of lung damage. Your oxygen saturation falls because of the change in the structure of the hemoglobin by the COVID virus. So your hemoglobin molecule cannot get associated and cannot carry 1.34 ml of oxygen. So it cannot get saturated. So how often? I would say in the first 7 days, you should do it at least 4 times a day. And if you are doing some exercise, please put it on and see, even in post-COVID patients, whether your saturation drops and your heart rate increases. Even if your saturation is not dropping and your heart rate is increasing very much, that means that your body cannot take this exercise. You require more oxygen.
We missed Dr. Ovik for a few minutes because there was some technical problem. He's back now, and Dr. Ovik will continue the proceedings. And
Yes.
Please, Arun sir, you'll be there, and he'll have the questions.
Yeah. Yes, Dr. Avik.
I was having, sir.
Yes.
Am I audible?
And sir,
Yeah,
very much audible.
Yeah, very much audible.
Sir, we are placing the
Sir,
questions on the screen also.
Okay. How can we judge cytokine storm clinically? So again, I respond that before the storm, there is pre-storm. Clinically, you will find that the person will have myalgia, fever, more than 101. His blood pressure will be dropping. His saturations will be on the lower side, may not be less than 95. His blood pressure will be lower than what he is going to have, and he may have anorexia. So all these clinical features where the person says, I'm not feeling well, is that you are having high cytokine. And if you have high cytokine in the first week, you be prepared for cytokine storm. So to understand the cytokine storm, you should do the cytokines in the first week. If they are high in the first week, they will be high in the second week, and so you are going to have reinfection with COVID. Is it likely to cause more severe cytokine storm than the first? So if your immune system had an asymptomatic earlier, so your system, your memory cells, your T cells, they felt that COVID virus entered, but you didn't have much, you didn't release cytokines. So the next time if you have it, the cytokines may get increased because there is going to be more chance of hyperimmune response. The same thing which is in dengue fever. Now, I have a very interesting finding that there is at least one paper which showed that in dengue, if you give steroid, because remember, dengue hemorrhagic fever or dengue shock comes only not in the first episode, but in the second episode. That means your body immune system has already knowing, and then it throws a hyperimmune response. So, role of prophylactic use of hydroxychloroquine and ivermectin, I will not advise you. Prophylactic use there is, yes, but not for hydroxychloroquine. You should have your ECG done very well. Ivermectin, yes, AIIMS Bhubaneswar has come up with a wonderful study, 2 doses, 18 milligram apart on first day and 3 days later. How frequently we need to do D-dimer, IL-6 and CRP. If you are sick, then you do it every 3rd day, especially in the second week. Remember, the second week is where it peaks. That is the period when storms. So you have to do more frequently in the second week, and you have to increase the dose of steroid in the second week. Even if you had given steroid in the first week and your patient was well, wait for it because you expect it to be high. Now, if supposing you had not given steroid, at day 7 your CRP was 100, in the second week it will go 200. But if you had given steroid and it was 30, you still expect to rise, but the rise will go to 50, not to 200. Should LDH be tested before starting antiviral drugs? No, there's no need of it. Anyway, antiviral drugs has got nothing to do with LDH, because LDH is a part of a cytokine rise. Once COVID, how long he is safe? I can't answer you very honestly, Rishikesh Majumdar, but I think that you are safe for a pretty long time. If you have clinical symptoms, then your body has produced antibodies and etc., and you are protected. So please share your views. Well, my views, again I repeat, all antivirals will only have a role when given as early when the virus was just entering your body, had just entered. Once the virus has stimulated your immune system, the virus has got nothing to do. The virus is just opening the lid. What your cell contains is what your body knows. So if you have a lot of cytokines stored in your lid, in your vessel, lot will come out. How long it will come out depend upon you. But if you want to, giving antiviral, you are trying to stop the virus from opening the lid. That you have to give very early. What are the minimum tests to be done when COVID is diagnosed? Well, madam, if you don't have money, if it's a poor person, don't do any test. If one test, that is CRP. One test, that's CRP. And if and monitor him clinically. So give him 3 equipments. One is temperature, 4 hourly, blood pressure, 6 hourly, and if you can use a pulse oximeter at least 3 times or 4 times a day in the first week. And if his CRP is less, then you don't need to monitor him, don't need to do any test. If you find he's suffering from fever, even in spite of your treatment, he's suffering from malaise, his blood pressures are coming down, there is a pattern for lower side, then you do 3 tests. HSCRP, D-dimer, IL-6. But they are costly, unless until the government does it.
Sir, the next question is, reinfection with COVID, is it likely to cause more severe cytokine storm than the first episode, or less severe, or not related anyway?
Yes. If the first infection has been very mild, asymptomatic, then the next could be severe. But if the first was already symptomatic, then there is no relation. Then the next may be even asymptomatic, if at all.
Okay. Okay. Sir, the next question is, how frequently we need to check D-dimer, interleukin-6 and CRP?
So if you are in the first week, you can do it once. If you are in the second week and you find already it was raised in the first week, then you need to do every 3rd day.
Okay. Next question is, once COVID, how long he is safe? How long he or she is safe?
Well, I see this reinfection part is very, very doubtful. People are still struggling. There are studies which say there's no reinfection. There's studies which say that the first infection was so asymptomatic that there was no antibodies which was produced. But if you have had a symptomatic COVID, I don't think you are going to get reinfected. This is what is my belief. I can't support it through any study, but this is what is a majority of the people believe still in this.
Okay, sir. Please share your views on flavipiravir.
Yeah, so I have already said that all antivirals,
Yes.
they have no role when you are symptomatic, especially when you are admitted in a hospital.
Okay. Next question is, should LDH be tested before starting antiviral drugs?
No. There's no need.
Okay.
Somebody has said many of us who are still not infected are continuing with weekly hydroxychloroquine monthly. I would say get your antibodies tested. If your antibodies is positive, stop this. And there is monthly ivermectin. There are not any studies to show that you are protected or not. I would say that just lead a healthy habits. If you want to get yourself protected, try it the other way around. Get yourself checked for your blood sugar. Get yourself checked for your lung function test. Get yourself checked for any other infection. Don't neglect those. And the other thing is that there is keep your windows and doors open. Don't be in a AC closed AC room. These are far more important, Dr. Sanjay, than trying to take ivermectin and feel you are safe. I would think that open air and open breeze is one of the very important factors. And don't work in a place, whether hospital or etc., where windows are all tight and you have a centralized AC. Centralized AC actually spreads more infection than it can. And even with your hydroxychloroquine and ivermectin, it may not be able to protect. Anyway, even the AIMS Bhubaneswar study only showed a protection of 40%.
Sir, I have recently seen a patient
Yes.
who is around 55 years old. There was only hypertension as high risk factor and nothing else. He recovered well from COVID-19. Now he is discharged, but the CT scan shows fibrosis in the lung fields, and he is maintaining saturation without oxygen at home. I want to ask you that what precautions he should take in future to avoid uh, the complications related to those pulmonary fibrosis.
So there are three messages I would like to give. One is that most of the doctors neglect the early symptoms. They think that this is a routine viral infection or routine cough and cold, and I have not got COVID. My request to all of you is that when there is a pandemic, even a simple infection which you think is a routine infection, you must get yourself COVID tested. And if you still don't want to get it tested, get your cytokine tested. By day 5 or 6, even before you realize, your lungs are already getting infected. And if you suffer from 1-2 days more, the cytokines, as I told you, they start rising in the first week. And by day end part of the last week, they are on the up. And the second week, they really peak. So where you are treating, where you are getting the patient, you have to know. If you are getting on the uprise, then you have to do your cytokines very frequently. Now, in this patient, which you are telling Dr. Avik that now he has recovered, still do his cytokines. If the cytokines are normal, that means he is safe. Do his blood sugar, especially HbA1c, so that he doesn't suffer. Train his lungs to do breathing exercise. Ask him to walk in the morning walk when there's less fog out. Ask him to do breathing exercise. You can also use incentive spirometry or even blowing a balloon. All these exercises are good for his lungs. And if he knows swimming, he can also take up swimming. And give him a small instrument called peak flow meter. See the readings whether they are increasing or not. If they are low, then better put him on oral inhaled steroids and bronchodilators, because you want that the alveolar macrophages should not any further get stimulated and release cytokines and then cause damage further, leading to more infection.
Okay. Sir, are there any effective anti-fibrotic drugs?
Well, that's what I was saying. I was surprised myself to see that even metformin is also, but I think there are two medicines which are being debated all over the world. One is, of course, the Parfinex, and the other is Nintab. I think that both, you must be clear that the liver enzymes need to be monitored. Otherwise, these are good drugs, but the advantage of Parfinex is that it can also be given in acute state. And of course, the oral inhaled steroid is always useful along with the bronchodilators.
Okay. Sir, I think we should conclude now.
Yes.
Sir, we have one more question. Sir, in the wake of early start of steroid, is it advisable to take oral dexamethasone if the patient is not admitted? And what should be the initial dose to suppress pre-cytokine storm in an adult?
I would prefer methylprednisolone if it is a home-based care over oral dexamethasone. I will keep oral dexamethasone only for those patients who are going to be admitted. And in the first week, I will do a CRP and maybe an IL-6 if it is possible. As I go to the second week, I know now is the time that even if I had suppressed his cytokines, it will rise again. So I have to repeat it. If there is a rising trend, then I have to increase the dose of steroid. And the dose of steroid has to be based on the patient's response. You can start with 4, you can give 8, you can give 16, but let me tell you, never get into a fixed dose response. That's a myth. Let your patient decide what amount of steroid, and that will be based on your cytokine response. Just like for diabetes, you give you see the blood sugar and decide your medicine. Similarly, for blood pressure, you would see the blood pressure and you control your. Similarly, for steroid dose in COVID-19, you need to do your cytokines and decide the dose.
Dr. Dibbendra wants to
Should the COVID contacts take ivermectin? Okay, so as I told you, if you are an COVID contact, you should take 18 milligram. That's the dose in adults on today, and 72 hours later repeat it. And this would bring down by 40%.
Okay. The next question is, which investigation should be done of those who are working in COVID hospital?
See, Dr. Pulak, I would advise you something else. I would ask you that get your blood sugars done, get your blood pressures done, see that you are not suffering from any comorbidity, which is a hidden comorbidity, any morbidity, not comorbidity. That is number one. Number two, if the day you have mild fever or cough and cold or even some kind of itching in the throat, it is better to get RT-PCR done. And if this facility doesn't get at least a CRP done or get both done, that would be ideal.
Sir, I want to ask you the last question. It was recently reported that the mortality rate is highest among the gynecologists because they come in close contact with the patient. So, necessary having the additional doses to avoid those things?
So you are very right. You see, up till now, medical science has only been focusing to avoid droplet infections. Now, you know that COVID also spreads through, has also been found in stool and urine. My request to the obstetricians would be, whatever precautions you are taking during operation and etc., you see, you will not die of COVID, you will die of because hypercytokine response. So I would say that this is a good time to check your body for any comorbidities, to shed some of your weight, to have a healthy diet. All doctors, they miss their diet. So I would request you that please go ahead and do that. Don't miss your diet. Take a healthy diet. Take plenty of green vegetables, etc. Decrease your weight. Decrease your truncal obesity. Get your blood sugars done. Control it well. This I think. Because see, you cannot run away from this profession. And there are so many deliveries. And deliveries are emergency. So if you have to do a C-section, you can't say, I will wait till you are tested. So at best, you wear a PP suit, a proper PP suit, which is available, and do the surgery done. But let me tell you one very interesting study which is going to be published. If you wear a PP suit and wear a triple layered surgical mask, your operative time increases. So I will advise the surgeons that in between, they should leave the patient, go out, open the mask, take fresh air, or go into a room which has an exhaust, and then come back and complete the surgery. If it is taking time, don't continue to it, because you will be undertaking a lot of rebreathing, and that can affect your health very badly.
So the next question is, what possible cardiac and neurological complications after COVID how to access and prevent?
Well, every possible cardiac and neurological complication which you can think of can happen. It can happen because of cytokines. It can happen also because of the treatment which you give. So you are giving steroid, you can have myopathy, you can have increased blood sugars, which can again cause a lot of infections. So I would say that it would take a full lecture to find out what are the cardiac and neurological complications. But one thing I always say, that if you find a patient aged, please do troponin I and do an ECG. If the troponin I is high, it shows that there is a myocardial ischemia which needs to be treated. And if the ECG shows an arrhythmia, you have to set your steroid doses and also follow it up. This is as far as cardiac. For neurology, you can't. What is your take on vaccine? Now, Shanthan, this will be my last question because I think I'll not get food. I continue to stay in a hostel and they're going to lock it. So I'm sorry to say that tomorrow morning I have to travel again. So this will be the last. So my take on vaccine is that I keep my finger crossed. I will not advise those who have already suffered from COVID to take a vaccine, though this is not the official thing which the government says, because after all, any infection is also giving a natural immunity. So all COVID infections are natural vaccines. So if 1 million people have already suffered from this, why waste 1 million doses again? The other thing is that these are vaccines which really requires long-term testing. So I'm not the best person to answer to these questions, but please beware, because if health becomes commerce, then it is very difficult to get trusted. So I'm afraid that a lot of things which are happening in medical science, even getting published, even getting advertised, even being spoken by a lot of experts, may not be in the interest of the patients, but maybe in the interest of the commerce. So that debate keeps on going. And personally, if you ask me, one should be very, very careful before you take such vaccines.
Okay, sir. Thank you. I think now we should conclude the session. You have given such a beautiful presentation, and we will be looking forward to have you in our programs in future. Thank you.
Thank you, Avik, and thank you. I thank all the organizers and those who are behind the screen. So, Avik, can you name the people who are behind the screen, whose faces we have not seen? Please thank them on my behalf. Can you name them?
Okay, sir. I think we have Dr. Nirmallo Das, Dr. Mrinal Kanti Ghosh, Kajol Bonik, Dr. Buddha Bhattacharya, Dr. Arup De, Dr. Shankar Nath, Dr. Shivaji Kaur, Dr. Pradeep Kumar Das. Sir, the list is long.
Yes, but I also would like to thank a lady who is not a doctor. Right?
Yeah, she has organized the whole thing.
Yes. So let us give
all the technical issues.
Yes. So please name and let us give a big clap to her, because the whole session went without any problem. So from my side, I would like to congratulate Dr. Avik. Why don't you name and give a big clap before we close down?
Okay, I think she is Mousumi, I think.
Nirmalla, can you get her on before we finish off? Yes, she is Mo Chakravarti. Mo. Yes, she is Mo Chakravarti. So congratulations, Mo. And thank you for this excellent Namaskar. Thank you for helping all of us, because you really helped me to communicate to all of you and the others to communicate with me. So thank you, Mo, for this excellent organizing. Thank you. Thank you. So good night, everyone. Please stay safe. And once again, I'm thanking to the Association of Health Service Doctors for organizing such beautiful platforms on which we can communicate. Thank you.
Thank you, sir.